it's a difficult thing to do cognitive behavioral therapy. So at this point of time, the easiest thing to do is learn cognitive behavioral therapy or motivational interview. These are the two things they do for psychological factors or any mood disorders or anything. So you need to learn to do either of those things. It's not easy to do, but you can learn in probably 6 months or something like that. That is the thing to do.
Sir, when the patient is like more chronic or when they need like, let's say a longer duration of anxiety or depression, like let's say they have it for 6 months or 1 year, what I do is generally at that point of time I use the reserve. But I think like it's good to manage patients who are at initial stage.
I know the problem is we will also try to discuss when in my session also. Pain is an emotion, right? It is not. Mostly we learn pain as though it is a sensory input, right? Like touch or temperature and things like that. But it's an emotion. What is the neurobiology of emotion, or why saying it as an emotion is different is emotion is a construct. What I mean by construct is you make that up. You make that I'm happy. Am I clear? Your experience makes yourself happy. Your experience makes you, or you construct in your mind that you are depressed, or you have you are not happy, or happy, I'm irritated and things like that. Because it's a construct, it has to be, it cannot be differentiated. It is difficult to differentiate anxiety and depression first. Most of us can't differentiate, even the therapists can't differentiate, and the scales also can't differentiate. So when you add pain into that construct of depression and pain and anxiety, it is difficult to say that, okay, this cognitive behavioral therapy is for pain, this is for depression, or this is for anxiety. அந்த மாதிரி பிரிக்க முடியாது. It cannot be பாகுபடுத்த முடியாதுன்னு சொல்லுவோம் இல்லையா, அந்த மாதிரி பண்ண முடியாது. So it has to be done together. Because it has to be done together, you need to have idea about all three. You can't just be saying that, okay, go and do CBT for depression and then come back to me for pain. அந்த மாதிரி அது it doesn't work like that. If you have depression and anxiety also, you don't get CBT for anxiety and then CBT for depression. It is for the whole thing. And as you also seen, CBT is still not working very well for anxiety and depression. One thing which has slightly better evidence, it's slightly better, is mindfulness. So you can, if somebody can teach them mindfulness, that will be the sort of soft solution, I suppose, at this point of time, rather than understanding and doing this and that. So that is the solution. I don't know, and also
Maybe you can add.
now the problem is we assume that psychology is different from biological issues, but that's a dualistic principle. That is, mind is different and the body is different. You know, the dualistic approach of mind and matter, mind and body. That's what Descartes is. You should have seen that picture of fire and car learning. Our idea on that the mind was different and the body was different. That's why he was completely wrong. So having defining ourselves, saying that this is under my scope or this is not under my scope, it's a blurry line. So I don't see any point in that. If you have an understanding, if you are a psychologist, clinical psychologist, and if you have understanding of pain and anxiety, okay, well and good, they can do that. Similarly, we can do that also. And the other issue is, if you treat pain as just the talking therapy, what I mean by talk therapy is cognitive behavioral therapy or motivational interview or something like that, it doesn't work. It has to be along with exercise and things like that. ஸோ அதனால் இங்கே தனியாக இந்த ரூமில் வந்து ஐஎஃப்டி பண்ணுவாங்க, இந்த ரூமில் எக்ஸசைஸ் பண்ணுவாங்க. திஸ் இஸ் ஜஸ்ட் very poor idea. It has to be together, because as I told you, these are all emotions and you can't slice it out. It cannot be done like that. One of the problems in our horrible physiology books is it gives you as though that the pain goes from here to here, the sensory cortex, and you understand pain. That is not how it works. We will also try to understand probably later on why that is not true also. Okay? Any other questions? என்னது?
நான் சொல்லியிருக்கேன், ஏன்னா அவங்க வந்து ஒரு 6 months 7 months என்கிட்ட வர்றாங்க, they have confidence in you. So நீங்க போய் ஒரு கவுன்சிலர் பாருங்க அப்படின்னு நம்மளால சொல்ல முடியும்.
So we were talking about in the health model about the stigma of so if you tell somebody that they have to go to a counselor, people will look at you as though you are mad. So that's not happening. So that's another issue. That's why I tell you that the softest way to do this is go to mindfulness, because they don't think that it's a psychological treatment. Actually, it is one of the best psychological treatment. So you need to have a slightly circuitous route. And also the other thing is, I can explain perception in English better than in Tamil. So if I have patients who are not understanding, already a lot of people don't understand what I speak. If they can't understand, I find it difficult to make them understand. ஏன்னா பெர்செப்ஷனுக்கு தமிழ் வார்த்தையே எனக்கு வந்து சரியாக இன்னும் புலப்படல, என்ன யூஸ் பண்ணோம் அப்படின்னு. The common example I tell them is, you think that this is yellow, right? It's a construct. It is not yellow. We all decided one day that this is yellow, right? So it's a construct. How do I tell this in Tamil? I find it still, it's still difficult for me to understand. What I mean by construct in Tamil வந்து எனக்கு இன்னும் தெளிவாக சொல்ல முடியல. And also the other thing I tell patient is, you are saying this is yellow and this is black and things like that. What is your organ which is required to do that? Yeah, I know. The brain, right? You need to understand that this is yellow and this is dark and this is light. The eye just sends your light to the brain, right? That is the same thing with the pain also. That's what you want to explain to your patient. Because a lot of people understand that, okay, eyes are not seeing that this is red or things like that, right? It is you understanding this is red, because when you were small, kindergarten apple is red and solli koduthanala we are telling that this is red. We all construct that this is a red color. We all construct that this is anger. The society constructs to you that this is anger. Because most of your if you studied physiology, they would have told you about two things: fight or flight. அதுதான் வந்து பொதுவா இருக்கும். You will not have happiness, physiology of happiness, physiology of this and that, because that is our basics, fight or flight. Afterwards, we construct that this is a happiness. He has a very small child. He smiles. I'm pretty sure he's not smiling, right? He's doing something. Because what is funny for him at 3 months, right? We construct that he is happy, so we are also happy, right? So we construct that. When you construct those things like that, it is difficult to slice it into, okay, this is happiness and this is sadness and this is depression and this is pain. அந்த மாதிரி பாகுபடுத்துறது வந்து it will be slightly difficult, right? Again, how do I explain these things to your patient? There is certain amount of trial and error, and sometimes it takes us 1 hour And the next day patient comes and asks me the same question. Because, because remember, knowledge is not behavioral change. தெரிஞ்சா மட்டும் நம்ம வந்து சேஞ்ச் ஆகிட முடியாது, ரைட்? இப்போ எல்லாருக்குமே தெரியும் ஹெல்மெட் போட்டுட்டு தான் வண்டி ஓட்டணும்னு. ஏன்னா கீழே விழுந்தோம்னா மண்டை உடஞ்சி போச்சுன்னா செத்து போயிடுவோம். அப்படி இல்லைன்னா மோர் வேர்ஸ் யூ வில் பிகம் an cognitively dysfunctional person, right? But we will not. இதில் இன்னொன்று என்னென்னா, பின்னாடி உட்காந்துருந்தா போட தேவையில்லை. ஏன் பின்னாடி இருக்கவங்களுக்கு மட்டும் மண்டை உடையாத? Right? We have this, even though we understand, even though we see a lot of people with head injury, we won't change, right? So knowledge is not change. That's why it will take 7 months or something like that to make them understand. Sometimes it's easier. We don't know what are the factors which influence all these things. Why it is easier, why it is difficult. We are still not very clear with it. As he was also pointing out, we confuse correlation with causation. ஒரு பேஷண்ட் நல்லா பண்ணாரு அப்படின்னா, okay, I told them very good information, or I did a very good cognitive behavior therapy. We assume like that. It mostly we know that. ரெண்டாவது நாள் அதே இது இன்னொரு பேஷண்ட்க்கு சொன்னீங்கன்னா, they will be like, okay, what time can I come tomorrow? அல்லது நாளையிலேருந்து உன்னை பார்க்கவே மாட்டேன்ப்பா, நான் வேற இடத்துக்கு போகிறேன்றது. That's how they will react. So it is still not sure what is the causal relation between this and this. It will take another 50 years probably. When you are older, you may have, younger people, we may have a slightly better understanding as we understand more and more what we call as connectomes. That is how the brain is connected and the tracks are connected. What we study in our physiology book is extremely wrong, or it's mostly wrong, the neurophysiology we study, or it is very reductionistic. Very reductionistic means it's ஒரு சின்ன பாட்டை வந்து they will explain rather than it as a whole. Say for example, he was talking about what symptoms you were saying, uncommon, or what symptoms were you saying? Non-specific symptoms. Irrelevance. That's a wrong word, I think. Why? If you are happy, right? It's a construct. I told you it's a construct. Happiness can invoke so many things into that one particular word. Sometimes if you are happy, you may jump up and down, right? Sometimes you might have a cry, right? Sometimes you may slightly laugh inside, right, rather than showing it out. What it means is, if you are activating your so-called happiness networks, it goes to different parts of the brain and it activates different parts of the brain. There is no one blob where it goes, okay, happiness na indha edathukku poradhu, appadi pogadu. So it will give you irrelevant symptoms, if you will. Right? That again comes from our not understanding the construct of depression, or construct of happiness, or construct of these things. Am I clear? So you need to understand that, and to make you more confused, the so-called Broca's area, Wernicke's area, which we think that is the language area, that's complete nonsense. Complete nonsense means complete nonsense. Why? Because ஒரு இடத்துல இருந்து ஸ்பீச் வர முடியாது. If you see when I am speaking, you can see that I am moving my hands, so there should be some activity in my motor cortex, right? That is, vocal cords are activating, so there should be some activation of the motor cortex. I am talking all these things because I have read and I have retention in my memory, so I should be activating probably my hypothalamus, that cortex, this cortex. So there are hundreds of things I am activating. So just say that the Broca's area is the speech area, it's just a reductionistic way of looking at it.
Smile, so volunteer smile and emotional smile.
Right. If you have a volunteer smile and an emotional smile, or real smile and a fake smile, they will tell you the difference. If you see in any photo, you will be like, right? Which is not really a smile, we just activate the muscle. When you're really happy, even Duchenne, it started with the Duchenne's electrochemical activations, the activity of the the rhizorius and the zygomaticus. He was the one who started activating these muscles with what we do now as electrotherapy. He told he only showed that it will go like this if you just activate the muscle, but that's not a we know that's not a smile. When you are smiling, you are activating more muscles and doing a lot of things. Okay? So if you have to understand the brain as such will be activated, not one part here or there. It may not be always like that. Sometimes it may be like that, sometimes it may be different. That's where our fMRI studies or PET scan studies will always give you a very limited approach, because you're lying and seeing something and then they are measuring your emotion and things like that. So it gives you a little amount of understanding rather than a whole lot of understanding. Okay? We have any other?
Perception of pain something. அது social element நாங்க research பண்ணோம் கோவிட் அப்போ எவ்வளவு பேருக்கு கேட்டிருக்கீங்க வந்தாங்க பெயின்
Right.
ஏன்னா அந்த வயல்லாம் போய் கோவிட் பயம் எல்லாம் போய் அந்த ரிசல்ட் பார்த்தா ரொம்ப ஆச்சரியமா இருந்துச்சு அப்போ பெயின்ல என்ன பண்ணுறாங்க.
Correct. And also you will see the other thing also, which is you will not believe that this is not just for pain. Your heart attacks gets lesser. That is, admission for heart attacks gets lesser and lesser people die actually. So a lot of why they are coming to you is also far more perceptual issue than just I have pain so I am coming to you. They may correct, because affordance is one of the important factors. What I mean by affordance is என் பக்கத்தில் வந்து இதெல்லாம் வாய்ப்பு இருந்தது அப்படின்னா நான் போகிறதுக்கான வாய்ப்புகள் வந்து அதிகம். தூரத்தில் இருந்தது அப்படின்னா போகிறதுக்கான வாய்ப்புகள் கம்மி. இப்போ நீங்கள் எஸ்ஆர்எம்ஏ எடுத்தீங்கன்னு வச்சுக்கோங்களேன், ஒரு 20 வருஷத்துக்கு முன்னாடி அவங்கெல்லாம் எங்கே போனாங்க, எந்த ஹாஸ்பிட்டல் போனாங்க, ட்ரீட்மெண்ட் எடுத்தாங்களா, யாரும் எடுக்கல இல்லையா? பட் சடன்லி யூ கெட் அ ஹாஸ்பிட்டல் தேர் அண்ட் எவ்ரிபடி கெட்ஸ் அ ட்ரீட்மெண்ட் ஃபார் back pain, neck pain and things like that. So the affordance part of it is vital. Okay. திருப்பி வரலையப்பா? அவன்கிட்ட தான் போகணும், அவன் தான் சொல்லணும். அவன் போட்டுருவான். So we are going to talk about pain, because we will, it's been a long time, we will also talk more about the physiology and things like that, because I can finish neck pain in 2 minutes. One is tell them to be active, another one is make them do exercise. Whatever exercise comes to your mind, ask them to do. Other than isometric exercise. Isometric exercise is not an exercise, that is just a waste of time. Right? So I think we have already seen that. So, now I just wanted to என்னப்பா அதான் மாதிரி இது. Okay. Right. So there are two parts to it here. You can see there is a sensory part and a emotional part. Now the sensory part is what you study in the so-called pain gate theory. Remember pain gate theory, Wall and Melzack, Wall died earlier I think. Melzack later wrote more theoretical ideas about all these things. So if you are thinking that pain gate theory is a theory, that's just nonsense, right? It's just a very, very small part of how the pain is working. Pain gate theory is not a theory at all now, right? So there is a sensory issue and an emotional issue. What it means is there is some pathways to go to your brain, right? That is, you get you get an injury, there is a chemical reaction here, right? If I have an injury here, there is a chemical reaction here, what we call as nociception. It goes to my your spinal cord. From the spinal cord, it has 2 or 3 pathways, lateral pathway and the medial pathway. It goes to the brain. That is your sensory part. What is the emotional part is, as I told you, it does not goes to the, it does not go to the thalamus and your sensory cortex. It doesn't work like that. It goes primarily to many, many areas. One of the primary areas which we usually don't read is your limbic system, right? Even though the modern understanding of limbic system is slightly different than what we usually think about limbic system, but that's all right. So it goes to the limbic system as well as your cortex, especially two parts of the cortex. The sensory part mostly ends up in your sensory motor cortex, if you will. And the other important part of it is it goes everywhere, or it goes to many places, what we call as a distributed system, right? Like your internet, if you send a mail, it goes whoosh. It doesn't go from your computer to his computer, right? It goes to a lot of places and then goes to the, so it goes to a sort of predominantly a distributed system, and it also goes to your limbic system and your frontal brain, where probably there is emotional element involved in that. Why I am saying probably is because we are not very clear about the emotional pathways. A lot of earlier understanding was probably it is something to do with our limbic system, but nowadays people think that it goes to many places, and as I told you, pain is a construct of a lot of things are involved in that, right? Now, in a sensory system, in just the sensory part of it, you can have two reactions to that sensory information, right? Because it's a sensory information, you can have two reactions to it. One is fight or flight. Am I understood? You can fight the pain, or you can be like, okay, I'm afraid of this, I have to be closer to it. Am I clear? But the fight and flight is not just a sensory information, it becomes an emotional experience. Because we are humans, we have emotional experience also, right? So that emotional experience is varied. What I mean by varied is, some people might think that this is just a pain. I will, as Hari was pointing out, they may be like, this is just a pain, I don't want to go to the hospital, especially in COVID times. But for some other people, the emotion might be like, this is pain, I have to go, even if I die of COVID, I have to go and see a physiotherapist or an orthopedist. So it gives you a far more complicated emotions, which can be, which cannot be encapsulated. What I mean by that, இப்படிதான் இருக்கும்னு நீங்க சொல்லிட முடியாது. It may be so much variability in that. That's why I think that we have to assume that it goes to different parts of your brain, not just your limbic system or your frontal brain and things like that. Right? So that is where these things come into play. That is, if you have pain, it is not just biological, it will be psychological and social. You cannot differentiate that these are biological factors and these are psychological factors and these are social factors. They will be always intermingled, right? இப்போ நீங்கள் வந்து சாம்பார் வச்சுருக்கீங்கன்னு வச்சுக்கோங்களேன், you can't say this is water, this is பருப்பு. You can't do that in a hostel if you are eating in a hostel, but you can't differentiate this is this and this is this and this is this, because they are all confluent into one thing, right? They are all mingled into one. So it is difficult to slice it, but we slice it because it is easy for us to understand. It is easy for us to learn. Am I clear? But in a patient, mostly it is difficult to differentiate. These are the biological factors, these are the psychological factors. ஏன் அப்படின்னா அவங்க பெயின்ன்றதே வந்து, as I told you, it's a construct. They have learned this is pain, this is how I have to react to that pain, not yesterday or day before yesterday, from the time of birth. Right? When you fell down when you were small, everybody came and picked you up, so you are learning, oh my God, if I shout, people will look at me. So that learning happens from your small, when you are small. So if you think that biological is just the sensory part, that is a very big no. Right? It cannot be sliced like that, as I told you, because it is always two parts to it will be always there, right? Now these are the newer IASP or some people are there for the pain. So they have given the bullet points along with the definition of the pain, right? So As you can see, basically what they are saying is, don't assume that nociception is pain. What they mean by that is, don't think that a sensory experience is a pain. It is not. It is always together with other things. That is, you learn what is pain. Like how you learn what is happiness. A lot of us think that, especially if you are in Tamil Nadu, especially at our age, not you I suppose, we thought that movie going was a pleasure experience, right? Nowadays my son does not see movies. He thinks that that's just a waste of time. I'm assuming all of you cannot sit for 3 hours first, right? Because it's too long. Where is the next slide, or where's the next reel, something like that. So we learned that Rajini movies are fun, and if I see it now, it looks like cartoon, right? Really cartoon, right? So we were taught that this is happiness, especially if you go to the first show, and that too if you bunk your classes and go to the movie. That was the height of experience of happiness, right? So this is how I learned what is happiness. Likewise, you learn what is pain throughout your life, not just yesterday when you had low back pain, right? So you want to understand that sensory and emotional parts are inseparable, right? And as for any sensory impulse, right, there will be a reaction to your system will react. As I told you, it will either fight or fright, right? So that emotional, that reaction will lead to adaptive changes in you. The system will adapt. The common example is, mullu kuthirchina moda adaptation நம்ம என்ன பண்ணுவோம், we will lift our heels, right? If it is in the heel, then you will do this. Likewise, if you have a back pain, the system adapts to something. You just don't know what is the adaptation. அதுக்கு தான் உட்காந்து எல்லாம் தடவிட்டு இருப்பாங்க, right? As though that adaptation is the problem of all, right? So the system adapts. Sometimes the adaptation goes beyond. That is where what we mean by lot of your psychological and social adaptations becomes larger, right? People will be like, or collar வேற மாட்டி விட்டுருவாங்க, they will be going like this, bike ஓட்ட விடாதுன்னு சொல்லிடுவாங்க, right? So these adaptations becomes stronger. Everybody is told that they should not ride bike, but everybody will ride it, right? Only few will stop it, right? That's what I mean by, if every person adapts to it in different manners, right, depending on hundreds of factors. And because it's an emotional experience, one of the good examples I learned is, யாரையாவது நீங்க வந்து போடா பண்ணி அப்படின்னு சொல்லிட்டீங்கன்னு வச்சுக்கோங்களேன், as we usually shout at people, right? Even Thiruvalluvar said that if you வாயினால் சுட்ட புண் ஆறாதுன்னு சொல்லியிருக்காரு. I don't know why, but it seems that we can have an emotional scarring. Likewise, if you tell your patient that உங்க பேக் கதை முடிஞ்சிச்சு, உங்க நெக் கதை முடிஞ்சிச்சு, உங்க இதெல்லாம் சேர்ந்து போச்சு அப்படின்னு சொன்னீங்க அப்படின்னா, the emotional reaction is going to be higher in some people, not in everybody. Again, it depends upon their experience, depends upon lot of other things, right? So be careful in how you describe the pain. Don't describe as though you are talking to matter of fact மாதிரி describe பண்ணாதீங்க. அவனுக்கு புரியும்படியா describe பண்ணணும், and also it should not be increasing his bad emotions or his nocebo, rather than making it slightly in a truthful manner, but in a subtle manner, right? So these are the things we want to remember about pain, right? Now, I'm not asking you because I'm assuming these are the causes. Everybody will tell that these are the causes of back pain, right? Now, this is where one of our problems in our education, especially in medicine, not just physiotherapy, whole of medicine, is we can't, or we don't even learn the word called as causation. That is, A causes B. We also think that in a complex system, causation can be found, right? Causation of why something is changing. We assume that the causation can be found. This got this got a boost when we understood lot of causal factors for a big group of disease which were killing us, that is the germ theory. When the germ theory started, we understood that for a lot of things there is a causal relation. That is, this microbe or this virus or this bacteria is what is causing my malaria or diphtheria or typhoid, tuberculosis, whatever. Right? But it's been 50 years, right? We still have tuberculosis. We still have malarial deaths. We still have this and that. Why? Why we are unable to remove the causal factor or change that? Because we understand that it is not just the malaria, or it is not the malarial virus or microbe. It is more than that, right? Our city has a beautiful river which is a breeding ground for whatever disease microbes you want, right? Until and unless we clean the comb, this is not going to go, right? So you understand that the causal relation is not that simple. Now, when it comes to other disease, especially non-communicable disease or causal relation, we don't have the slightest clue what causes this, right? People are always astonished when I tell them that nobody can find out why you get what is the cause for low back pain or neck pain or things like that. So if you are also thinking like that, you have to answer yourself, what causes diabetes? What causes Parkinson's? What causes heart attack? What causes stroke? If you know that answer, that means you are poorly educated. There is no answer. So you should not think that I know the answer for that. Right? We have this wonderful word called as risk factors. What it necessarily means is, எங்களுக்கு தெரியாது இதுவா இருக்கலாம் அப்படின்றதா risk factor ஓட idea. Because now we know that in the 90s, cholesterol was considered one of the biggest problem or one of the biggest risk factor. Now people are thinking it may not be as risky as other factors. So it is not clear in hundreds of conditions where we know the cause. But what we know is, we know the treatment for them. We don't need to know the cause, but we can know a good treatment. Right? This is where I think Thiruvalar was also wrong when he said, "Noi nadi, noi mudal nadi." You cannot do that. It's a good philosophy, but you can't do that. Because our biological systems are complex systems. Complex systems react very complicatedly. So if you send A, it may not produce B. If you send A and B, then it may not produce C. Just an example, right? It does not react as linearly as other things. சரியா? இப்போ நீங்கள் காரை கொண்டு போய் அந்த தென்னை மரத்தில் மோதினீங்க அப்படின்னா, that's a linear thing. We know மோதினோடனே எங்கள் முன்னாடி இருக்கிறதெல்லாம் வளைஞ்சிரும். சில சமயம் நீங்கள் போய் மண்டையை உடச்சிக்கலாம். சரியா? But if it is a complex state system, it doesn't work like that. It is very difficult to know the causal relation. And as I told you, you don't have to worry about that. You will not know the causal relation for many conditions, but we will know a better treatment for that. Right?
heredity disease எங்க அப்பாவுக்கு வந்து லோ பேக் இருக்கு, ஸோ எனக்கு லோ பேக் ஒரு அந்த மாதிரி கேசஸ் சார்.
If you have in genetics, have you heard the word epigenetics? Right. So if you have diabetes, right, back pain is not hereditary, but if you are diabetic, right, so they tell you that if your mother, your father, and your paternal மாமா அல்லது மாமா உங்கள் தாய் மாமன் இவங்களுக்குலாம் இருந்தது அப்படின்னா, then your chances of getting it is very very high. right? That is, you have that gene for getting a diabetes, but diabetic gene does not, what's the word I'm thinking for, express itself. When it expresses, when you have some environmental factors, it expresses. That is, when you are putting more weight, you are eating lots and things like that, you are stressed and things like that, there is a bigger chance of that gene expressing, right? So you can, to some extent, in some conditions, if there is epigenetics, that is the expression of the gene is happening, then you can play on that. That is, you can have some preventive measures. But if it is like Duchenne myopathies or spinal myopathies, we can't do anything, right? We are assuming that these are the genetic factors for that. Even if you know the causal factor there, you can't remove that gene. At least now we can't remove that gene or things like that. Sometimes the exact opposite happens. That is, you know the causal relation, but you don't know how to treat it also. Right? Any other question you want to before?
So, we know it is hereditary. Then can we have the prevention factors from the beginning?
That's what I'm saying. If it is epigenetics is involved, that is, we know that the gene expresses after something, or the risk factors for that expression, then we can, but otherwise we can't. Say for example, as I told you, diabetes is probably genetics. It is not purely genetics, but it's probably, because there is epigenetics involved, that is, it expresses after the conditions are ripe for it to express, right? That's why we keep on telling, some people get diabetes at 30 or 40 because of so many environmental factors. One of the common examples I can give is, you're all younger. How many of you are non-vegetarians? Right. Weekly எத்தனை நாள் சாப்பிடுவீங்க? 4, 5? Right? Especially பசங்க அப்படின்னா நைட்டு ஃப்ரைட் ரைஸ் சாப்பிட்டு வீட்டுக்கு போகிறதுலாம், I'm assuming it's very common. When I was small, or Hari could know that, we used to get only on Sunday, and அரை கிலோ கறி எடுப்பாங்க. My son can eat 1 kg of chicken, right? So we are eating more, but we are exercising less, right? So the environmental factors are allowing, or it is getting ripe for the epigenetics to happen, right? So it does not happen, you cannot prevent it all the time, because again we don't know what are the factors which are causing that, but we can have for some conditions, we can sometimes delay it, sometimes we can even prevent it, right? So one of the conditions which don't have a causal relation is, mostly pain doesn't have a causal relation until and unless you have a frank trauma. கீழே விழுந்துட்டு அப்போ அடிபட்டுச்சு அப்படின்னா, because we know the sensory path is activated, right? This is how it was activated, because somebody punched me, I fell down, so we know the sensory pathway is activated, so you can have some idea, okay, this is what is causing it. Otherwise it is difficult. One of the common example I tell all my patients when they tell me, really you don't know the reason, I ask this question, do you know why you are getting headache? Stress? Over? Okay, you cannot stop thinking at all, right? We are always thinking. That is the point of conscious, right? So we may say that these things are cause, but it's just a correlation, right? Because you know that you get headache even when you are not overthinking or when you are not stressed, right? You go to a movie, right? When you come out, you get a headache. Until you are inside the movie theater, you are not getting a headache. A lot of people get that, right? Why? No, eyes lam paakama irukka mudiyadhu. There is nothing called as eye strain, because if you are opening, you are always putting something in, right? It's not going away anywhere. These are all again correlations. We just don't know. Am I clear? வெளியே வந்தாதாங்க உள்ள தானே சவுண்ட் இருக்கு, ஆனா வெளியே வந்த பிறகு தானே தலைவலிக்குது இல்லையா? Right? So, and also remember, if you had a headache, and some people get it every day, right? Some people don't, some people get it once in a while, right? Why are we not running to the doctor?
You know it gets better.
because we have an experience, we learned that the concept of headache, I told you we construct what is an headache, right? The construct of headache, we learn from seeing others, we learn from ourselves that it goes away after 1 hour. Am I clear? That's what we mean by learning what is a pain. Learning construct of pain. என்னைக்காவது ஒரு நாள் பேக் பெயின் நெக் பெயின் வந்த பிறகுதான் we are suddenly perturbed and we think something is happening. And it's happening in the last 20 years, it is getting worse. One of the reason is every day you open your Facebook or your Instagram or somebody is talking about if you do this for 10 times, if you do this for 10 times, somebody is telling you something and you are thinking something is happening in this world, right? So and you start constructing about neck pain and back pain and things like that. You see people who are going to the என்னங்க டெய்லி எங்கே போயிட்டு வரீங்க, பேக் பெயினுங்க, ட்ராக்ஷன் போட்டால் தான் எனக்கு சரியாகுது. ஆனால் you get that construct. Am I clear? So you understand the construct between headache and the construct between back pain. So that's where the emotional parts of it come into play. You cannot differentiate. Okay, இப்படி தான் அவர் லேர்ன் பண்ணியிருப்பாரு நீங்கள் சொல்ல முடியாது, because it is happening throughout his lifestyle. Am I clear? Right. That's why I think calling it as a mechanical neck pain is one of the most nonsensical thing about biology. Nothing in biology is mechanical. It is all biological. What I mean by biological is probably chemical, probably electrochemical. Mechanical pain la onnum kedaiya. Yana mutta pay vara elditan idha vera ellarum sollittu irukanga. Right? So this idea of saying that this is a mechanical pain, something is stressing this and that is just a correlation. You are seeing it in the X-ray and thinking that this has happened. Remember, X-ray எடுக்கிறதுக்கு முன்னாடில இருந்து அவருக்கு சேஞ்ச் ஆகாமையா இருந்தது. It has changed long time back, right? You just took a X-ray yesterday, right? So this idea of mechanical pain is not a wonderful idea. This doesn't correlate, right?
Only that whatever severity radiograph shows, patient they prove that
Yes,
radiograph is very damaged, but patient won't see pain.
correct.
Same patient won't have either.
Correct. That's why correlation is always confusing. You will not have a proper correlation. That is, you may have your X-ray may show that, oh my God, you have so much of degeneration. Exactly. That's what we meant by how to explain pain to a patient. Right? The emotional content becomes larger when you show it, and இதை வேற வந்து படம் வேற போட்டுக்குவாங்க, எக்ஸ்ரே வச்சு காமிக்கிற மாதிரி வேற. And also people have this spine in the table as though it is to show this and that. These are all bad ideas. Correct. Right? So I also don't like this word myofascial pain. Pain is pain. There is no myofascial pain or dental pain or romantic pain, girlfriend pain, boyfriend pain. There is nothing. And cervical spondylosis, again, it's a misnomer, assuming that the system degenerates. This is what I tell my patients: all systems will degenerate, because then only we can die. All systems will degenerate. Your skin is not. This is not how I looked when I was younger, right? This is not how my hair looked. I'm also losing my hair. I have to get married. So all systems will degenerate. Only thing you want to remember is, if you tell that this system is degenerating, it becomes worse for them, right? So better it is to call it as non-specific pain. Because why non-specific? Because your symptoms will be non-specific. Your reasons will be non-specific. We may find it in another 50 years again, but until that, it doesn't matter. Right. So what is the assessment we have to do? Nothing. What I mean by nothing is, இப்படி அமைக்கி பார்க்கிறது, it doesn't give you any extraordinary information. especially there's a book called as Maggie, that's what everybody reads. None of the test is useful for, I'm pretty sure whoever has a clinic has never done, except for anterior and posterior drawer test. None of us do any of the tests because it doesn't give you any information. SLR is a useless test, completely useless test. I will tell you why it's also useless. So what you want to ask then, right? What does you mean by assessment is you want to ask what are the problems they have because of back pain. The common things you will notice is they will have issues with working, they'll have issues with doing cooking, that's what I mean by working, or they may also have, a lot of people will have issues with sleeping also, because if you have neck pain, to get it into a correct or in a best way to sleep, it will take long time, so you're sort of going around and around. So find those things out, right? You can also look into the range of motion and things like that, but the most important thing is the issues of activity and participation, right? How well you can participate with your neck pain, how well you cannot, or you taking leave because you have a neck pain, are you able to work on the computer and things like that. So that kind of things is what you need to have a assessment, right? And the last part is the treatment part of it. We have most of our treatment, if you look into it, is based on the idea of sensory information as a pain, right? That is, there is an issue in my back or in my hand or in my shoulder and things like that. So if I remove or manipulate that, the pain will go away, assuming it as a sensory information, right? Because our understanding of the physiology was also poor, also our understanding of the biomechanics, so-called biomechanics, was horrendous. We thought that biomechanics was a reason for a lot of things, and we know that it does not work like that. So there are two types of treatment. One is assuming that it is, I know the reason for that, so I try to change that sensory information. In that, we will have all sorts of manual therapy, which can include rubbing your skin. What's that called as?
IAST.
No, you can rub with your hand, right? Without, you don't need a pencil or anything, right? So you can rub the place, all right? That is basically what we are doing. I'm giving an explanation rather than using the. I'm using a vinatual rather than noun, I suppose. And you do a manual therapy. You try to correct this and that. You try to put it in the right place. There is a whole bunch of videos on putting it in the right place, as though the hand is going this way and you're like, no, come this side, right? As you can imagine, there is no biology like that. It cannot go out and come in and then stay in also, right? Even if there is a going out, if for example, if there is a dislocation, if you put it in, that doesn't mean it will go away, right? Again, right? So that's why you need a long rehabilitation process. You need you need to keep it in that place for quite some time and then strengthen all your muscles to stop it from going there, right? So that kind of treatment does not work due to the problem of assuming that pain is just a sensory information, right? And the next thing a lot of people tell me that when I tell this is, it worked for me, right? It worked in my clinic. Now, vela paakra clinic la idu work aadu. It definitely will work. Talavaliki amrudanjan thechone talavali poichu illaya, right? There's nothing in the amrudanjan to make your headache go away, right? So it's just a correlation that it will go away because it goes away anyway. தலைவலி மருந்து எப்போ போடுவீங்க? தலைவலி வந்தோடனே ரொம்ப பதிகமான நம்பர் தான் நம்ம போடுவோம் இல்லையா? ரொம்ப அதிகமாக போயிடுச்சுனாலே அதுக்கப்புறம் அடுத்து என்னது? It should start coming down because that is the nature of headache, right? So தலைவலி மருந்து போட்டோடனே கொஞ்ச நேரத்தில் வந்து we think that it is going away, right? That's what he mean by heuristics. That is, what is there is what is the truth for us, right? So, lot of times, that's why they tell you to compare it with something else. If you are doing manual therapy every patient, then you can't find out, right? Because every patient is getting the same treatment. So compare it with something else, right? You just think about like this. எவ்வளவு patient நம்மட்ட வராம இருக்காங்க, அவங்களுக்குலாம் எப்படி சரியாகுது? As he was pointing out, COVID அப்ப நிறைய பேர் நம்மட்ட வரவே இல்லை. அவங்களுக்குலாம் எப்படி சரியாச்சு? It means it recovers by itself. Right? Most of our back pain and leg pains recover by itself. And he was talking that there is a common chance of it again and again happening again and again. The recurrence, one of the common reasons for recurrence is getting more treatment. Getting more treatment. That is passive treatment. இப்படியே அமுக்கி விட்டுட்டே இருந்தீங்கன்னு வச்சுக்கோங்க, it's like having a wound and keeping on scratching it, right? If you just don't do anything, it goes away most of the time, right? Or you have to do something active rather than passive. So there's another group of exercise will be your or another group of treatment that will be your exercise. In the exercise part of it, there is a Cochrane review on exercise for neck pain. I think there are many Cochrane reviews which are horribly nonsensical, and this one is I believe the worst review, right? Now if you have an exercise, right, there are only probably two types of exercise or something like that. I really don't know, but anyway we will assume that we are doing some exercise and we will try to find out why that is wrong. Now, what is the principles of exercise? ஒருத்தருக்கு exercise கொடுக்கணும்னா what are the principles you need to have? You should follow some principles, right? So what principles we follow mostly? Overload, specificity, progression, okay. Sorry? There is nothing called as coordination. Coordination comes in, you can't do anything about that. That's not a principle necessarily we want to have for, that's for exercise physiology now. So you need to have overload, right, and repetition, right? How many of you are giving strengthening exercise for back pain? We all are giving, right? How many of you follow this principle of overload and things like that? Overload பண்றோமா? Are we progressing? No, first tell me what is overload you are giving.
Let's say your patient is doing 3 or 5 exercises on day 1.
The day 1 la we will assume 3 exercises there. Tell me one exercise. Pelvic bridging, right? Where is the overload there? No, then you are not necessarily strengthening, you are doing endurance exercise, I suppose, right? So most of the time it is not necessarily strengthening exercise, we are giving exercise most of the time, whether it is back pain or neck pain. Most of the time we don't follow any of those things, but we call them as strengthening exercise, but we don't follow any of those principles, right? Most of the time, right? We sometimes do an endurance exercise, but for the endurance exercise, how many repetitions should be there to be into an endurance exercise?
15 to 20.
That's not endurance, right? That too for a tonic muscle, that cannot be an endurance. For a back muscle, it cannot be an endurance, right? So we just give an exercise, that is all. You cannot subclassify them as motor control exercise. That is one of the nonsensical word I have ever heard anything, right? So we give exercise. We rarely give strengthening exercise, but strengthening exercise should be ideally with resistance which they are slightly above. That's when it will become overloading, right? If for back pain there is only one exercise, probably lying and doing extension, probably there is some amount of overload. Otherwise, it rarely happens, right? So we do exercise. So subclassifying it as, sorry, go ahead.
Let's say in a session your patient is doing 10 or 15, like 2 or 3 sets of 15. So the duration will be around like 30 or 40 minutes. So how do you see this?
I understand that. For us also it takes us 30 minutes. After 3 days, are they still doing it for 30 seconds? Exactly. It takes a lot of time to learn in the first 2 days, so it looks as though it is half an hour, right? The next day, third day, fourth day, you will see that it is finishing in 15 minutes, right? Because they know how to move, they know how to do that. So the learning makes it sort of shorter, right? So mostly pragmatically, we seem to be giving exercise. We are not necessarily doing following any principles, right? Why I am saying this is where the evidence is also lacking. What type of exercise, what overload, nothing is very clear about that, right? But we know that any exercise works. That's why I am not for classifying exercise into different groups and things like that, right? You can say that we did rested exercise, but it does not necessarily mean that you gave an exercise regime according to the Oxford or DLOM or any of these things, right? So exercise, what does the evidence say? It seems to suggest that it works, right? We are still not clear, especially for acute pain, right? But out of all these things, what works seems to be it's just this is just a diagram from one of the RCTs. You don't have to do the same thing, but basically what they are telling is you want to do exercise for your scapular region and your neck region. That is your bottom line, right? You cannot do just exercise for your neck alone, and the neck isometric exercise is rarely done. You need to have isotonic exercise, side lying and moving your neck, and supine lying and flexion of the neck. These are far better exercise. And also a lot of people do the deep flexors. They will tuck in the chin and lift the head. Right? If you don't know how to do it, you go on to go and see it, because that's another exercise which seems to be done in all the RCTs. Right? So you want to do exercise for your scapular region and your neck region. If you just do stretching and do rubbing, mostly it doesn't work as good as doing the exercise. So you do that exercise also. Regarding pain education, that is the next part of it. The treatment, which it's getting very late, so we'll try to finish faster. So regarding the next part of it is the pain education. The problem with the pain education is two things. One is all the pain education which is written until now was written probably in Australia or in US, which does not relate to our patients. One of the common questions they ask is, உருளைக்கிழங்கு சாப்பிடலாமா அப்படின்றது வந்து ரொம்ப முக்கியமான கொஸ்டினாக இருக்கும். பேக் பெயின் வந்ததோ நெக் பெயின் வந்ததோ அப்படின்னா என்ன அர்த்தம் அப்படின்னா அவங்க பெயினோட கான்ஸ்ட்ரக்ட் இஸ் டிஃப்ரெண்ட் தேன் வாட் தே கான்ஸ்ட்ரக்டட் இன் US or in Australia. So we don't know the health model. We were talking about the health model earlier. We don't know what is what. So until even there, what they have written is அவன் நினச்சதை எழுதியிருக்காங்க. Nobody has gone through the process of the theoretical understanding and then writing and things like that. So education is poorly done, and also a lot of people think that education தனியாக கொடுக்கணும், exercise தனியாக கொடுக்கணும். Again, that doesn't work. As I told you, it all has to be combined together. Correct. அது தனி ரூம் இல்லையா? அதுக்கப்புறம் தான் right. So there's a compartmentalization rather than making it all together. So you want to have education along with your treatment, right? And also, I also noticed that if you keep on talking without the patient getting any value out of your treatment or any change he is perceiving, you can talk until the cow comes home, nothing will change, right? So you need to have sort of a different way of doing education, which sadly we still are not very clear. Only thing which I use is also trial and error. It's not necessarily based on complex theoretical ideas, especially adult learning, health models, and then we have to go into how to make up those things. Right? So that is the point of it. You give exercise and education for back pain, electrotherapy, and things like that. Those are all rituals. If you have to have that rituals, you have to have it, because there are other factors which are into play. One is somebody is sending you the patient, so you can't just say that I will not give it. So you need to have that rituals, but I am not concerned with that. The concern you should have is have a robust education and a robust exercise, probably with resistance, right? This is not an exercise, this is just moving your hands, right? So even if you don't have overload principle, there should be some resistance to it. So that kind of exercise will be always better. So if you have any questions about scapulothoracic exercise, you can go and very well see those things in scapular and neck exercise. You can easily see in the net and understand those things. So yeah, so that's it about the management of acute neck pain. Okay, so we will have questions for another 2 minutes and then we will finish. So you have any other questions? Thank you, Pastor.
Treatment now, what they're doing is requirement oriented. You should go to functional and quality. As opposed to this, what patient wants, definitely not different. He doesn't bother whether I'm reducing vascular from 7.
Correct.